Welcome to 6 in the A. I'm Chao-Wei Hwang of the Johns Hopkins University School of Medicine and the Frederick Health Hospital. Today's case is a case of stent dislodgement in the left main. Our patient is a 55-year-old man who is morbidly obese. He has high blood pressure, hyperlipidemia, diabetes, coronary artery disease, status was an MI, and ischemic cardiomyopathy, and he has a biventricular ICD. He had stenting of the RCA and of the proximal LAD with DES about 2 years ago. He now presents to the ER with a few days of crescendo chest pain and exertional dyspnea. His troponin was 1.1 nanograms per milliliter, his ECG showed a paced rhythm, and his echocardiogram showed an ejection fraction of 35%, which is unchanged from his baseline. He was referred by the cardiologist for coronary angiography and possible PCI. His Barbeau test was unfavorable, so right femoral access was obtained. On diagnostic angiography, the right coronary artery has diffuse mild to moderate plaque. The stent in the proximal RCA is patent and with some mild in-stent restenosis. The left circumflex artery has diffuse but moderate non-critical disease. In the LAD, the stent is patent, but you can see that right here, there is a focal area of in-stent restenosis that is somewhat difficult to appreciate. In the spider view, you can see that there is a D1 and a D2, with the D2 being larger with an osteal lesion. The stent in the proximal LAD is patent. Again, there's a suggestion of focal in-stent restenosis, which was difficult to appreciate in this morbidly obese gentleman. We therefore performed fractional flow reserve measurement, and the FFR value of 0.72 suggested that the lesion was in fact significant. So we decided to proceed to PCI. Our plan was to perform provisional stenting of the LAD and balloon angioplasty of D2. We opted against a two-stent strategy due to the presence of a previous LAD stent. Our thought was that if D2 turned out to be compromised, then we would perform TN protrusion bailout. The angle is actually relatively favorable for TN protrusion. DK crush and culotte were felt to be not ideal, again due to the presence of the previous stent. The LAD and D2 were wired fairly easily. The LAD was pre-dilated with a 3.0 millimeter compliant balloon, and D2 was pre-dilated with a 2.5 millimeter compliant balloon. We then had some difficulty advancing a 3.5 by 18 millimeter drug-eluting stent into the LAD. The stent was able to cross into the LAD, but could not cross into the in-stent restenosis area. We then attempted to remove the stent for more lesion preparation. That was actually quite difficult to do, and finally, when the equipment was withdrawn, we noticed that the stent was actually stripped from the delivery balloon and looked like it appeared to be sitting right here from the left main into the LAD. We actually scanned down the guiding catheter, hoping that the stent would be somewhere in the guide, but unfortunately no. The stent was in fact stuck in the left main into the LAD and perhaps protruding slightly out of the ostium of the left main. So when you have a dislodged stent like this, the first thing you need to do is ask yourself 3 questions. Number 1, do you really need to remove the stent? Number 2, is the stent still in the coronaries? And number 3, is the stent still on the wire? So we assess our situation. We have a dislodged stent from the left main into the LAD, clearly not an ideal position. So we thought that we should at least try to remove the stent. The stent is in fact still in the coronary tree, but part of it may be just outside the left main ostium, and the stent is still on the wire. So how do you approach a dislodged stent? Well, here's a decision tree that I find to be quite useful. The first question you ask is whether you really need to remove the stent. If the answer is yes, then you ask yourself, is the stent still on the wire? If the stent is still on the wire, then there are several techniques that can be used to remove the stent. Those include the balloon technique, a guide pinning technique, a wire entanglement technique, or snaring it. If you have to remove the stent but you've lost wire, then your only options are really to snare it or for surgical removal. If you decide that you don't have to remove the stent, then you ask yourself whether the stent is in the coronaries or whether they're in the peripheral artery. If they're in the peripheral artery, most of the time you can actually just leave it there. If the stent is in the coronary and you decide that you don't have to remove it, then you ask yourself again whether the stent is still on the wire. If you have wire access, then you ask yourself whether you can pass a balloon through the stent. If you can, well, then you just deploy the stent. If you cannot get a balloon across, or if you've lost wire access, then your option is to crush the stent. So back to our patient. We decided that we wanted to at least try to remove the stent because it was located from the left main into the LAD, clearly a suboptimal area. We tried the balloon technique first. The balloon technique basically involves trying to slide a balloon through the stent distally, inflating the balloon distal to the stent, and then withdrawing the stent and balloon together. Now, if your stent is not too badly mangled, it can sometimes actually come right through the guide and out, leaving the wire behind. But in general, most of the time, the stent is mangled enough that the whole system, including the stent, guide, and wire, may all need to come out. In our case, we attempted to advance a 125 balloon through the stent, but the 125 balloon was actually stuck right at the ostium of the stent and could not cross. So unfortunately, this was not successful for us. We next tried the guide pinning technique. The guide pinning technique involves essentially trying to advance your guide catheter around the stent, sheathing the stent within the guide, and then pinning the stent against the wall of the guide with a trapping balloon that you've deployed in parallel inside the guide, and then withdrawing the entire system. Sometimes you can attempt the same technique with a guide catheter extension as well. And in general, using this technique, the stent, the guide, and the wire will all have to come out. So what we did is we tried to advance the guide forward, but unfortunately it looks like it got stuck and would not cross the ostial edge of the stent, which looks like it was flared out. We tried the same thing with the guide liner and similarly could not pass the guide liner past the flared ostial edge of the stent. And here's our attempt to advance the guide liner to sheath the stent, and you can see that the guide liner is getting stuck at the ostial edge of the stent. We next attempted the wire entanglement technique, and what the wire entanglement technique is to pass multiple wires through the stent, essentially entangling them together intentionally to trap the stent and then withdraw the whole system. You can actually combine the wire entanglement technique with the guide pinning technique that we just described. So what we did is we advanced 4 different guide wires through the stent cells, twirled them together as much as we can to entangle the stent, and we tried to withdraw everything out. And unfortunately, when we did that, not only did the stent not come out, but we actually lost wire access. You can see that the guide is now over here, all the wires are gone, and the stent is still stuck right here. So now, unfortunately, we have a situation where we have a dislodged stent, but no wire access. We attempted to try to snare it, but that was unsuccessful as well. But with all the manipulation, the stent now appears to have been pushed forward or perhaps just deformed now in the distal left main into the LAD. You can see the ostial edge of the stent kind of sitting right here, right near where, right in the mid to distal segment of the left main. Because of this, we decided to just crush the stent in place. We rewired the LAD, the D2, and the circumflex, and that was actually done relatively easily. A 4.0 by 28 millimeter DES delivered relatively easily and was deployed from the left main into the LAD and crushing the undeployed stent against the wall. We then also stented the proximal LAD with an overlapping 3.5 by 18 millimeter DES. We then performed kissing angioplasty of the LAD with D2 and followed by POT in the left main. And so here's the final angiographic result. IVUS confirmed that the stents were well deployed and well opposed. The patient actually remained stable throughout and did well overnight and was discharged home the next day on prolonged dual antiplatelet therapy. The patient actually had another cath 1 year later because of chest pain and a positive stress test. And reassuringly, it looks like that the stents are still widely patent. The circumflex is patent, although the ostium might be slightly pinched, but overall the result still looks fairly good. So here's some take-home messages. If you're faced with a stent dislodgement case, keep this decision tree in mind. Ask yourself first whether you need to remove the stent. If you do, and if you still have wire access, then you can try using the balloon technique, the guide pinning technique, wire entanglement, or snaring it to try to get the stent out. If you don't have wire access anymore, then snaring or surgical removal are your only two options. If you don't need to remove the stent, ask yourself whether the stent is still in the coronary. If they're not in the coronary, then usually you can just leave it there. If the stent is still in the coronary, then ask yourself whether you still have wire access. If you do, then you can try to see whether you can pass a balloon through it. If you can, just deploy the stent. If you can't pass a balloon through it, or if you've lost wire access, then your option is to crush the stent. Thank you for watching. If you enjoyed this video, please subscribe to our channel. Thank you.